Right. Thank you, Helen, and thank you, Tim, for inviting me to come and talk about long COVID and really the overlap with ME/CFS, which is what I'm really going to concentrate on. Before I start, let me just sort of introduce myself. I'm a doc with personal and professional interest in this disease called myalgic encephalomyelitis, or chronic fatigue syndrome, which I've had for around about 40 years. I got interested in this subject because I developed this illness myself after catching chickenpox from one of my patients while I was a hospital doctor. And so I've been involved in virtually every aspect of ME/CFS for, as I say, 40 years. I'm medical advisor to the ME Association, which is the major patient support charity for people with ME/CFS. And I've been, amongst my many other roles that link to this, I've been a member of the committee at NICE, which has produced a new guideline on management of ME/CFS. And there's a lot of information in that guideline on ME/CFS, which I feel is relevant to people with long COVID, especially the information that we've placed in there about activity and energy management and pacing, and just symptomatic management, which I'm going to come on to, obviously, in due course. As Helen said, I created a short list of resources which came along with the presentation. These are all free downloads from the ME Association. There's a booklet there. It's quite a long, detailed booklet, which really covers what I'm going to talk about during this presentation. So there's probably no need to be taking notes because virtually everything that I'm going to say is there, but in more detail. So that's a review of the clinical and pathological overlaps between ME/CFS and long COVID, the diagnostic process, the clinical assessment process, and what we can do in the way of management of people with long COVID who have got ME/CFS type symptoms. There's a comprehensive booklet there that we've just updated. I've just updated, which covers activity and energy management and pacing, which is terribly important part of the management of both conditions. And there's a new booklet which we've just published. It's available from our website. I think it just went out today, on pain management, which is another obvious component of the two. So I'm going to talk about, as I say, this overlap between long COVID and ME/CFS. Let me be very clear at the onset. I'm not saying that long COVID just equals ME/CFS, but what I am saying is that there is a lot of overlap between what seems to be causing long COVID, and there's a lot of overlap between the symptoms that people with long COVID have and people with ME/CFS have. And this really needs to be a two-way process, which I've been trying to put forward to both patients and my colleagues in the medical profession since all this debate into long COVID and interest in long COVID started, in that there's a lot that we can help people with long COVID with in the way of symptom management. And at the same time, because there's this huge amount of money being poured into research into the cause and management and treatment of long COVID, hopefully both groups are going to learn from that as to what is really causing these post-viral conditions and how we can manage them better. Because at the moment, as I'm sure everyone here appreciates, we don't have a treatment for long COVID. We don't have a treatment for ME/CFS, and we are stuck with, managing symptoms, which is not a satisfactory way to be proceeding. So this overlap between ME/CFS and long COVID, where did it come from? Well, as I'm sure everyone's aware, this pandemic of COVID, it started off really at the beginning of 2020, and it was interesting, really, not long after that, it was around about May that I put out our first sort of guide to what may be happening between the two conditions. So it was only a few months after the start of this pandemic that we were picking up and hearing about people who were just not recovering from long COVID. And these weren't the people who'd been seriously ill in hospital with chest and heart and neurological complications from COVID, who'd been really quite seriously ill. The majority of people that we were hearing from them were, as we hear from people with ME/CFS, they were previously fit, often fit young adults, no health problems. They got COVID. Most of the people we were seeing at that stage hadn't been admitted to hospital. They'd been managed at home. In many cases, they'd been self-managed and hadn't even seen a doctor. And they may not have had a terribly serious episode of COVID, but they weren't recovering from the COVID. And 3 months on, they were complaining of this awful debilitating fatigue. They had this brain fog. They had problems with pulse and blood pressure regulation. They weren't sleep properly. They had aches and pains. Some of them had COVID-related symptoms, obviously breathlessness, chest pains. But there was a very strong cluster of symptoms which were ME/CFS-like. And so we started to get interested in this subject and pointed out, I was working on the NICE guideline at the time, that there was this enormous overlap between the two in many cases. And this wasn't really surprising to us, because if you know anything about the history of coronavirus infections, COVID-19 is not a new coronavirus infection. There have been other outbreaks of coronavirus type infections. One was called SARS, one was called MERS, 10, 20 years ago. And when the doctors at the time of those epidemics started looking at what was happening to the patients, many of them were not recovering in the same way. Again, around about 10% were developing this sort of ME/CFS-like illness. So ME/CFS and long COVID are part of what those of us who are involved in this sort of area regard as post-viral diseases. And there's a whole range of post-viral diseases. And what they seem to have in common is these core symptoms of fatigue, brain fog, what we call dysautonomia. That's problems with pulse and blood pressure regulation, what comes out as POTS. Their sleep is unrefreshing. They have various aches and pains. They have interesting symptoms like alcohol intolerance as well, and sensitivities, chemical sensitivities. They may develop allergies. So they have these core symptoms. But on top of these, they have other symptoms which are very specific to the particular virus that triggered that particular condition. So in the case of my own ME, I have all the sort of post-viral symptoms that are common to both conditions, long COVID and ME/CFS. But because chickenpox is a virus that affects the brain, I've had, since I developed my own chickenpox, I've had a severe problem with balance, because part of my brain, which is called the cerebellum and helps control balance, is affected as well. So I have my ME/CFS-like symptoms and I have my chickenpox symptoms. And if you look at the range of other post-viral diseases, which I think this long COVID and ME/CFS fits into, whether it's hepatitis C, Zika virus, these Ebola virus, it's not just confined to what we call sort of Western viral infections. This is something that you see in tropical countries. There's an interesting condition called chikungunya, which is found in India, where people have joint problems associated with this. So the real bottom line here for these post-viral diseases is the symptoms that they all have in common, and then another box of symptoms which is very specific to the infection which triggers that particular set of symptoms. Before I just go on to long COVID and its symptoms, just a few sort of facts on, just to clarify what I think we ought to be meaning by long COVID. So I think the best definition of long COVID is failure to recover from what has been either assumed or clinically diagnosed as a COVID infection, preferably with a positive COVID test, but it's not essential. And it's this failure to recover after, and I think the timeline here is important, because it's the same sort of timeline we use in ME/CFS, of around about 3 months, because there's a lot of people with viral infections, applies to COVID as well, ME, all kinds of infections. People get a post-viral syndrome, post-viral fatigue syndrome, which is relatively mild and resolves itself within a few weeks or a couple of months. But when these sort of symptoms persist for 3 months or more, and they're having a significant effect on what people can do in the way of work, family life, social life, all aspects of their life. The symptoms are persisting and having this really quite significant effect on quality of life. I think you then can put the diagnostic label of long COVID in the case of COVID, or ME/CFS in the case of other symptoms. And what we know from what is emerging about people with long COVID is that in addition to your core ME/CFS-like symptoms, your COVID-related symptoms, there's a whole range of other symptoms that people have. I mean, if you look at the literature, there's anything up to 200 different symptoms being ascribed to COVID. But the core symptoms and the COVID-related symptoms, the breathlessness, the chest pains, this is in most cases what is causing this severe level of disability that comes with this illness. So there's a range of symptoms, there's a range of severity. One end of the spectrum, just like ME/CFS, there are people with mild COVID, what we might call moderate COVID, and then, as with ME/CFS, a group of people who are very severely affected, who may even be bedbound, housebound, wheelchair bound, and are very severely affected by this. And what's also emerging, and these papers are now starting to come through, is from the people, the epidemiologists and others, who are looking at what's happening to people with long COVID in the long run. And we're starting to get these studies through of what's happened to people over a period of 2 years. And there's a good paper, probably one of the best papers, I think, came out in the Lancet a few days ago. We're going to put it on the MEA website. I'll put it on our Facebook page later today. It's a very good study looking at long-term outlook in a group of people. I think they were from Spain, who'd got COVID. And I think the key point of this paper was that while some people with long COVID are improving and getting better, there is a significant proportion of people with long COVID who at 2 years are not improving and are not recovering in the way that one would hope. So I think we are dealing with, I know we are dealing with a very serious condition which is not going to go away, and we desperately need some sort of treatments to help people with this. So just to recap on the symptoms of long COVID that I've been talking about, we've got this box of COVID-related symptoms, which is related to what happened to the lungs, the heart, the liver, the kidneys, the brain. I mean, this is an infection that goes to virtually every body system, or can go to every body system. So you've got your shortness of breath, your persistent cough, your chest pain, your problems with smell, loss of taste, disordered smell and disordered taste. And I think you put those in a separate box because I think they've got a very specific cause. We know what it is. It's the COVID that's caused that. It may have caused damage to the lungs, damage to the heart. This may be temporary, it may be resolving. In some cases, sadly, it may be permanent. There is the box of ME/CFS-like symptoms, the fatigue, the cognitive dysfunction, problems with things like POTS, pain, sleep disturbance. There's a separate box which applies to some people, as it does with ME/CFS, which is mental health symptoms. So some people, not surprisingly, with an illness like this, become depressed, become anxious. In some cases where it's been a very severe illness, which has been very distressing, there may even be a post-traumatic stress disorder component to it. Another group of symptoms which I think is very important in the clinical assessment of people with long COVID, and partly why I believe that people with long COVID must be assessed face to face. You've got to do this in the consulting room. You've got to take a proper history. You've got to examine people with long COVID and do all the relevant investigations. Zoom consultations are not the way that we should be dealing with patients with long COVID, because one of the other things we know with long COVID is that it is seems to be unmasking or making certain pre-existing conditions worse. And one of these that immediately comes to mind is diabetes. It seems to be precipitating people who are perhaps predisposed to having diabetes in the first place, more likely to then develop type 2 diabetes or have an exacerbation of type 2 diabetes. It may be that if you've got some sort of existing heart disease or predisposition to heart disease, then it may just trigger, maybe the trigger to actually produce symptoms in relation to heart disease. So that's got to be taken into consideration with what's going on. And so there may be symptoms from pre-existing conditions that have got worse that also form part of the package of long COVID. And the other thing that I really do need to highlight, because it's a major problem with people with ME/CFS, because all too often we come across people because they've got chronic fatigue. The doctor doesn't know what is causing this, and they get a label of ME/CFS as just a convenient diagnostic label, when they do in actual fact have another condition. And I follow the newspaper reports on long COVID here very carefully, and it really is, very disturbing to see what, I wouldn't say at regular intervals, but probably about once a month or so. There was one last week of a lady, she was a counsellor somewhere in Lincolnshire, I think, who had actually got lung cancer, which had been diagnosed as long COVID with continuing chest problems. So it is very, very important to look out for symptoms which we would regard as red flag symptoms: weight loss, persisting fevers, this sort of thing, when you're assessing someone with long COVID, to make sure that you're not missing some other totally different diagnosis and just blaming all these symptoms on long COVID. Just a quick word on what we know from statistics. The current monitoring of the number of people with long COVID, the best statistics that we have on this, certainly in the UK, come from the Office of what's called the Office of National Statistics, the ONS, and they publish regular data on what they estimate from the way they do this, and the number of people who've got some sort of long COVID, and the numbers are huge. I mean, the most recent data, it's in the MEA long COVID booklet. It suggests that probably we've got around about 2 million people who've got some sort of long COVID. The figures for 2 years, it looks around about 750,000 people, and people where it is having a significant impact on what they can do in relation to all aspects of social, family, employment life, or whatever, is round about 1.5 million. So it is an enormous subject. Next thing I'd quickly talk about, again, in our long COVID booklet, I've gone into this in a lot more detail and given some references and what, if you want to follow this up, is what is causing long COVID. Because if you know about what's causing a condition, then it's much easier to start treating it. And the sort of clues that are coming through, I mean, first of all, again, there was a paper, it came out at the beginning of this week. It's the first study looking at the genetics of long COVID, and we're doing a big study called Decode ME at the University of Edinburgh to see if there's a genetic predisposition to ME/CFS. And the first results from this paper, it was published in Nature, I think it's on the MEA website, certainly on our Facebook page, was suggesting that there was some evidence of a genetic predisposition. So in other words, some people are genetically predisposed to developing an illness like long COVID or ME/CFS when the right trigger factor, a viral infection, comes along. Secondly, we go back to the COVID component to this, the specific COVID infection. And there is certainly some evidence, it's not totally convincing, but there's some evidence, and this is where things differ from ME/CFS, that there may be pockets of persistent viral infection. They may be in the gut mucosa, as is being suggested, or there may be pockets of what's called the spike protein from the coronavirus. So it's not the actual active virus, but it's part of the actual part of the viral infection, a footprint, if you like, is left behind, to which the immune system continues to react. The second interesting aspect of looking at what the cause of long COVID may be in relation specifically to the COVID infection is this work which is looking at microclots, which is largely being carried out by a research group in South Africa. And they are suggesting that we certainly know that COVID in the acute hospital situation is a condition which affects the vasculature, the blood vessels, the arteries, and particularly the veins, and can cause what we call thrombosis, blood clots. That's very well established in acute COVID infections. But what is being suggested now is that there may be what are called little microclots being formed in the very small blood vessels, what are called the capillaries. And that this is an important component of what may be causing long COVID. This is early research, it's very speculative research, but it's led on to one particular form of treatment, which I'll come to in a minute. And then the third sort of to the ME/CFS overlap. And it's interesting to see we've got all this money being poured into looking for the cause of long COVID, and a lot of it is just going down the same lines as research into ME and coming up with very similar system component to this. And you properly, so you've got what we call low-level immune system activation. The immune system is slightly in overdrive, and there's some evidence that that may be happening in long COVID. There's also some evidence in both conditions that people are developing what are called autoantibodies. These are antibodies which are directed against the body's own tissues. They're not protective antibodies like normally make against a viral infection or an allergic condition. These are potentially harmful antibodies. We know in ME/CFS that people have a problem with the way the muscle creates energy through what are basically batteries within muscle cells called mitochondria. And it's interesting that there's some evidence also in long COVID that there may be this mitochondrial dysfunction, that the mitochondria are not functioning properly, these, if you like, Duracell batteries within the muscle. And this obviously may be an important component of why people with long COVID are so troubled by the debilitating fatigue that occurs. I said that there may be a persisting viral element to long COVID. We also know from the research that in both conditions there may be reactivation, or there appears to be the Epstein-Barr virus that causes glandular fever, which you've all had many years ago. But this virus remains dormant in the body, but you get a traumatic event like a COVID infection that stirs up the immune system and reactivates this particular viral infection. There's some evidence that as in many conditions now, and it's a relatively new area of medical research, that what we call the microbiome may be involved. And this is the composition of harmful and harmful and protective viruses and bacteria and everything else that normally live in your gut. And that there may be a disturbance in this ratio of harmful to protective bacteria. And people often don't realize that the gut and what happens in the gut and the microbiome has an important effect on the body's immune system. So that may be interacting with some of the immune system disturbances. And then finally, and this is a fairly new bit of research being carried out by a very good research group in the States, again, following up the link with ME/CFS, and they've been looking at what's called the hypothalamic pituitary adrenal axis. This is a hormonal axis from two glands in the brain, the hypothalamus and the pituitary, which sends messages to the adrenal glands, which sit above the kidneys, to produce a hormone called a stress hormone called cortisol. And we know that in ME/CFS, people have relatively lowered levels of cortisol. There is dysfunction in this whole axis. And I don't think any other research group has done this. So I think this research group in the States is the only one to report on this, but they have found the same findings of relative slight decrease in cortisol in the patients that they've been looking at. So overall, we have a lot of overlap between the two conditions. So how can we use those findings to actually treat the underlying disease process in long COVID? And here we're just running into the same problems that we've got with ME/CFS. We've got all these clues as to what may be going wrong with the immune system, persistent viral infection, the body's endocrine system, the mitochondria. But what can we do in the way of drug treatments to deal with this, as opposed to just dealing with ME/CFS? We don't have any magic bullet treatment for long COVID. I don't think there's going to be a magic bullet treatment for everyone with long COVID as we go along. But I think because there are so many studies now, I think there must be around about 100 clinical trials going on looking at long COVID. We are going to find before long treatments which are going to help certainly some people with long COVID. Now, I can't talk about all the different clinical trials that are going on at the moment, but among some of them that are, because of what we know about persistent viral infection, there's a trial looking at antiviral drugs. There are trials looking at, because of this microclot finding, or sorry, I'm just going to have a glass of water. I've got a bit of a sore throat today as well. So whether anticoagulants, which are drugs that we normally use to treat blood clots, might be effective. There's a very controversial process called apheresis, which is rather like kidney dialysis in that it removes clotting factors from the blood. That's a very expensive process. It's only available in private clinics, and you've got to go either off to various parts of Europe outside the UK to have this treatment. It's not something I would want to recommend at the moment without further information on it. There's an interesting trial, and this is one trial where we have got some results released. There's a trial looking at a drug, a supplement, amino acid supplement called AXA1125, which is being trialed by a very nice physician in Oxford, Dr. Betty Raman, who is using this drug to try and improve mitochondrial function. That's trying to get this battery in a better state of health, which is in the mitochondria, which is in the muscle and produces energy. There have been some trials looking at probiotics, which affect the microbiome. There has been some interest in a particular aspect, and I think this is possibly the only area where certainly some of the physicians that are involved in the long COVID services are keen to just give it a try, as to whether drugs which are called H1 and H2 histamine receptor antagonists can help, because there's some evidence that in some people with long COVID, just as with ME/CFS, there is what we call destabilization of mast cells, and mast cells are parts of the immune system which release a chemical called histamine, and this can produce sort of allergic type symptoms as well. So there is some evidence. It's largely anecdotal. There has been one one result from clinical trial, that it may be worth trying these mast cell stabilizers. They're rather like antihistamine drugs, to see if you can calm down this histamine response, which seems to be occurring in some people with long COVID. Otherwise, as I say, we don't at the moment have this magic bullet treatment, which we so desperately need to treat long COVID. And things like vitamins, minerals, supplements, or whatever that are promoted to people with long COVID, that is not the answer at the moment. So what are we left with? We're left with, as really with ME, it is treating the symptoms. Now, I'm not a respiratory physician or a cardiac physician, so I'm not going to try and give guidance on the treatment of people who've got long COVID with respiratory problems, lung problems, or heart problems, or delve into problems with taste or smell. These are very much the COVID virus itself symptoms. What I will say, and there are links in our leaflet to this, that there are good sources of help for respiratory problems. In addition to your respiratory physician that you could see at a long COVID clinic, there's a group called Physios for long COVID who produce, these are physiotherapists who are used to dealing with people who've got respiratory problems, obviously, and they produce good information. I think they also produce some videos, and there certainly are some good videos out there. My son works as a film producer for the NHS, and I know he's just been involved in making some videos with a physiotherapist on this very subject. But they are out there, and I think when he was at the Brompton Hospital in London, which is a major hospital for respiratory disease, they put some, and they're probably on their website. There's also the British Lung Foundation produces good information on the respiratory side. There are some organisations which are listed, links to them in the MEA booklet, who are producing, I think, good information on problems relating to taste and smell as well. So what I'm going to finish off with just talking a little bit about symptom management and where these are the symptoms, obviously, that overlap with ME/CFS. And I mean, the first major symptom is this very debilitating fatigue that occurs with long COVID. To my mind, having spoken to a lot of people with long COVID who have this fatigue, it's the same sort of fatigue that people with ME/CFS describe. And I think the best way of looking at it, and I've done a page on this in our book, but we've got, as I say, a full booklet on pacing, activity, and energy management. I think the best way of looking at what has happened to the body is that instead of having a full, large battery sitting there at the beginning of the day, you've now got a small battery which is not fully charged, and which, if you're not careful, loses its charge very quickly. And if you overdo it, then it's very difficult to charge that battery again during the course of the day. So this means you've got to plan the way in which you're going to use your energy throughout the day in a very careful fashion. And this is where I think you can learn from people with ME, because we've long established this process, what we call pacing, which is basically, certainly right at the very start of an illness like this, which is sadly gone out of fashion with the medical profession. People need a period of convalescence and rest, and then gradual reintroduction to what they're doing physically and mentally. But once you've reached a point where you've got some degree of stabilization in a condition like this, the essence of pacing is planning your day ahead, so that each day is going to be different. You're going to start the day with X, Y, Z amount of energy. So trying to plan your day according as to what sort of amount of energy you think you're going to have, how you feel at the start of the day. I mean, most people know whether they're going to have a good day, a grotty day. So plan the day, account how you feel at the start of the day, and then I suppose the core part of pacing is very much splitting what you're going to be doing physically, mentally, emotionally into little chunks. So you do a little bit of physical stuff, you have a rest, a relaxation, you do some mental stuff, you have some more rest, relaxation, etc., etc. You do that through the day. And as time goes on, hopefully if you are improving, then you gradually increase these little chunks of what you do physically, mentally, whatever, accordingly. But this is long COVID, just like ME/CFS, it's a fluctuating condition. Your condition is going to fluctuate as to what you can do from day to day, even from hour to hour, but from hour to hour, day to day, month to month. It's going to fluctuate, and it's going to be very unpredictable. So it's not something you can do in a sort of incremental fashion and expect to improve on an incremental way over a period of weeks and months. And this was, if you've followed anything that goes on in the ME world, this has been a big issue of contention within the ME world for a long time, because the previous guidance that was issued by NICE, which has always been opposed by the ME patient community, is the recommendation that came from various, I think, very flawed clinical trials, that people with ME would get better if they approach their activity management through something called graded exercise therapy, which involved very sort of inflexible, incremental increases in what you were doing from the point of view of activity management. And it didn't really matter whether you had pain or you sort of relapsed a bit, you just carried on and pushed on and pushed on and pushed on regardless, and you would get better. And when we examined all these clinical trials which had formed this guidance for people with ME over many years, during the NICE guideline committee, we came to the conclusion that all this research was very poor quality, and that not only we could not recommend graded exercise therapy for people with ME/CFS anymore, but we actually put a warning in that this was not an appropriate form of treatment for ME/CFS. And interestingly enough, I won't go into this in any more detail, but this has all blown up again this week with a publication of a paper in the Journal of Neurology and Neuroscience from a group of doctors who still feel aggrieved that we are not recommending graded exercise for people with ME/CFS. So I think if you've got long COVID, you need to be very cautious if you come across a doc who wants you to start on a graded exercise regime. And I think it would be very appropriate and very sensible if NICE looked at their guidance on long COVID and made the same recommendation there as they've done with ME/CFS. The other main obvious ME/CFS type symptoms that people with long COVID have is cognitive dysfunction. I think it's not only cognitive dysfunction, it's cognitive fatigue as well, brain fog, as it's commonly known. And as I'm sure lots of people here will know, this involves problems with short-term working memory, concentration, attention span, retrieving information, processing information, word finding abilities, so you mix up words, maybe even slur words at times, all these sort of problems. It is not, and I think this is where you certainly need reassessing if there's any suggestion that this is occurring. It's not a form of dementia. It's not, it's not a lack of ability to remember what happened in the past. It's very much a sort of here and now problems with memory and concentration, working what we call working memory. So if you've got other strange things going on with memory, then I think you need a proper assessment. Again, sadly, we don't have we've not been able to develop any drug treatment that's really shown to be effective for treating cognitive dysfunction. Again, with long COVID, there's lots of clinical trials going on looking at things which may help, things like coenzyme Q10, but the evidence just isn't there to recommend them. Just as I didn't mention this, we don't have a drug treatment for fatigue. I wish we did. I think sometimes doctors will prescribe things like amphetamines, thyroid supplements, but that is not something which is sensible to be doing in the circumstances. The third sort of main component of the ME symptom list is what we call in medical jargon dysautonomia, and that's a nice medical jargon word for saying that the body's autonomic nervous system isn't functioning properly. And the autonomic nervous system is a system of nerves which have control centers in the brain, and they pass messages via what are called the sympathetic and parasympathetic nervous system down to a whole range of different organs within the body. So the bladder, the bowels, the heart, and the blood vessels in particular. So you can get a range of different symptoms affecting these different organs that the autonomic nervous system controls. So as far as the bladder is concerned, you may get an irritable bladder type symptoms, frequency of urination. It may be a component in producing irritable bowel type symptoms. We know that people with COVID quite often have continuing bowel symptoms. I don't think this is all due to irritable bowel syndrome. I think it, as I mentioned earlier on, COVID, I think, can trigger other diseases which have been sitting there but haven't been apparent. So I think there's certainly some research evidence now to show that COVID can trigger what's actually called an inflammatory bowel disease, which is rather like Crohn's and ulcerative colitis. There also seems to be an increase in celiac disease post-COVID. But because of this autonomic nervous system dysfunction, these groups of nerves, parasympathetic, sympathetic, one of which speeds things up, one of which slows things down, you can get these disturbances in the way that these organs function. But the most relevant one is the effect on the heart that the autonomic nervous system has. So it can affect pulse and blood pressure. And we know that people with both conditions find it very difficult to stand up for prolonged periods of time. And this may be because the blood pressure falls when you move from sitting or lying down to standing up, and this makes you feel faint and woozy, and they feel sick, they feel sweaty. Some people, as part of this dysautonomia, get a condition called POTS, which is called postural orthostatic tachycardia syndrome. And this is where your pulse rate rises quite significantly between lying or sitting and standing up. So it's normally defined as an increase in pulse between what your normal pulse is sitting down and then standing up of 30 beats per minute. So if it goes up by 30 beats per minute, it may be that you've got this condition called POTS. And POTS is another very disabling component of both ME/CFS and long COVID, and a significant proportion of people with both conditions do have POTS. POTS can be a standalone condition by itself, but it's something that really does need to be properly assessed and treated. Certainly, if it's become more severe, by someone who knows about treating POTS, because it may involve changing fluid intake. And in particular, if it's more severe, there are drug treatments which can help with POTS, the drugs which can slow down the pulse rate, drugs which can increase the amount of fluid in the blood vessels. So if you've got POTS, do get some expert help from it. There are physicians, certainly in most specialist centres, tend to be physicians involved in cardiology who know about POTS, but I would recommend a very good self-help organisation called POTS UK, who provide really good information and guidance on POTS. And they also have a good section on their website, which is a geographical list around the country of consultants who specialise in POTS that people can be referred to.
Charles, can I just mention we are slightly running out of time.
Sorry, I wasn't looking at my watch.
Oh, that's okay. So I don't know if you're due to wrap up. So just want to go to questions. We've got a quarter of an hour left.
Yep, right. No, I've gone on longer than I expected to. Sorry. So right, the final thing that I'm going to just talk about very briefly is in relation to symptoms is pain. And pain management. So we've got a new MEA information leaflet on pain management. And there are certain drugs which we use in pain management for muscle, joint pain, nerve pain in ME/CFS, which I think can help in COVID. These are not normal analgesics. So there are things like using a low dose of a drug called amitriptyline, which is normally used in depression. This is a very low dose of it, 10 or 25 milligrams. And then sometimes for more severe pain, drugs like what we call gabapentin and pregabalin. These are drugs which are normally used to treat epilepsy but affect brain chemical transmitter symptoms, can be very helpful for more severe pain. Before I'm going to finish now, one just final thing, and it's not symptom management, but it's an important aspect of management, which I think I ought to mention, is in relation to employment. And there's been quite a lot of discussion to be covered by the 2010 Equality Act and all the protection that provides to people when they're requesting or wanting modifications to duties at work, hours at work, etc., and things at work. And at the moment, the 2010 Equality Act does not cover long COVID as a blanket. There has been one case, I'm not aware of any more, but I'm aware of one case where someone did show that their particular individual case should be covered by the 2010 Equality Act. The problem here is that to be covered by this act, you need to have a condition which is having a very significant impact on what you can do, and it also is going to be there for at least 6 months to a year. We have, as far as ME/CFS is concerned, established that this is an illness which should be and is covered by the 2010 Equality Act. And I think it will be very helpful to people with long COVID if some further clarification could be got on that, because I think it would be totally helpful for people with long COVID who want to get back to some form of employment. Right, I've gone on longer than I intended to do. So are you happy, Helen, to fire away with any questions that we've got?
No problem at all. So thank you so much for talking us through that. It's one of those topics that I think we could hear about, sort of all day. There's just so much to go through, isn't there? So some of the questions you might have actually answered as you've gone along, but let's have a little look. So obviously someone in the very early stages has said how similar is long COVID and ME. I think you've already kind of covered that, but is there any connection with sleep apnea? Is that something that you can answer today, or? Right.
I mean, sleep apnea is a very interesting condition, and it's a very important condition in what we call the differential diagnosis of ME/CFS, because a lot of, to have ME/CFS, you've normally got what we call unrefreshing sleep. So you just wake up, even if you had a decent night's sleep, you just don't feel refreshed by it. And I know a lot of people with long COVID have that. But when you're talking to people with ME/CFS about sleep disturbance, one of the things you should do is to take a very careful history, because sleep apnea, which is a separate condition, and I would say it is not linked to ME/CFS, but it is quite a severe condition, which causes daytime fatigue, causes cognitive dysfunction. So it causes, quite a few of these symptoms, and it should be considered as a possibility when you're making a diagnosis of ME/CFS. So whether there is any overlap, I'm sorry, this is an area where I haven't followed the research and literature. I'm not aware of anyone in the research area saying that there's a link between long COVID and sleep apnea, but certainly I think anyone who's got long COVID, who's got a significant problem with sleep disturbance, and there are various ways in which you can assess sleep disturbance. There's something called an Epworth sleep score, which you can get off the internet and have a look at. But certainly, if you've got a very severe sleep disturbance and you're having episodes of real daytime sleepiness, which can occur in long COVID, and you've got other risk factors for it. It can be it's more common in people who are obese, who've got a collar size, I think it's 17 or more. So there are some risk factors for sleep apnea. But I think the main message is, if you've got severe sleep disturbance with long COVID, it needs to be assessed, and it may need to be assessed in just like there are pain clinics, it may need to be properly assessed in a sleep clinic where they can do a 24-hour monitoring of what your sleep patterns are.
That's great. Just to say that if we do run out of time for these questions, do keep on putting them in the chat. We have agreed that we can send those on to Charles, and then we will get the answers, you know, sort of published on our website at a later date. So a lot of the links and resources that Charles has referred to will be sent out to you as well, including on energy management and pacing. So there's a question here about drug treatments. Someone's saying, I'd imagine these may be likely for long COVID as the source of the post-viral effect is clear. However, for people with ME, the original infection is often unknown due to poor diagnostic procedures, including late diagnosis. So how would this area of research benefit people with ME, if at all?
I think for the people with ME, I don't think there's probably going to be that much good news here, because you know, where you've got, as you've just said, you've got a very specific infection. We have now got some drugs in relation to COVID. I can't remember its name. Paxlovid, sorry. Yeah, I mean, there are antiviral drugs which are effective against the COVID infection, but as you correctly point out, ME/CFS can be triggered by a whole range of viral infections. You know, glandular fever, gut infections, chickenpox, parvovirus. You know, the list is endless. And for most of these infections, we don't actually have any specific antiviral drugs that are that effective. And equally, the evidence for these infections actually persisting in any sort of active form in ME/CFS is really just not there. I don't think, you know, this is something that research has done over many years, looking for evidence of persisting viral infection in ME. I don't think that persisting viral infection is a component, certainly for the vast majority of people with ME. So I don't think antiviral drugs are going to be the answer for ME, but they could be the answer for people with long COVID, or some people with long COVID.
We have a question around trials. So how can one access these trials, particularly if your diagnosis is for ME/CFS?
Certainly for ME/CFS, if you go to our website, there is a section on research, and we have a subsection there on volunteering for research. And certainly if we're requiring volunteers for any of the research that we fund, we make an announcement there. And that includes, which we're very keen to resume doing, we fund what's called the ME Biobank, which is a repository of blood samples. It's at University College in London. So we collect blood samples from people with all severities of ME/CFS and store these there and release them to research groups. And I think as time goes on, unless someone sets up a long COVID blood bank, you know, like the ME Biobank, I think we ought to look at perhaps enlarging this to include some long COVID samples as well, because this will be terribly useful to the research community, because it means people who want to do lab-based research into ME/CFS and don't necessarily have access to patients can come along and get blood samples that they want, and they get all the anonymized clinical data on these patients, and it's all there. They don't have to go out and chase patients in clinics and everything else. So we're supplying blood samples on ME/CFS all over the world to research groups through this facility. And we also have, because when we set up this probably 6-7 years ago now, of course, COVID wasn't around. So we decided we needed some sort of control groups, and our control group at the ME Biobank is people with multiple sclerosis. But, you know, what's happened now, I think we do need a long COVID biobank.
Yeah. That's great. We've just got a couple more questions. One I think you've touched on anyway, so you know you may well have answered this question, but someone who's been diagnosed with POTS, just asking if there's a connection between this and ME, CFS or long COVID, because it obviously seems to be quite common with lots of people with the conditions. You have gone through that already a little bit, Charles.
Yeah. And I mean, the connection with long COVID is now very solid. And I mean, I've got a collection now, probably a dozen good quality research papers of people who've looked at people with long COVID and looked at the incidence of POTS. Interestingly enough, and it was a very high figure. There was one in the American Journal, I think it's the American Journal of Medicine, earlier. It was either earlier this month or back in June, which came from some cardiologists in the States, and they'd suggested in their cohort that around about 60 to 70% of people with long COVID also have POTS. So it is a very common overlap with POTS.
Brilliant. Thanks for that, Charles. And I think one of the final questions here, although as I say, if people have got questions and they think about afterwards, please do email ourselves at Healthwatch Northumberland and we can get those passed on. So Graham's asking for details of the booklets. Yes, we'll send on all the links again. And we also have someone who's asking, saying that they've had COVID 5 times, had 4 vaccines, and they've had long COVID since the first infection. So asking really about how reoccurring infections affect recovery in the long term.
Well, I think sadly this is a bit like the picture that we have with ME/CFS. I mean, one of the main, in fact, it's probably the main trigger factor for causing relapse or exacerbation of ME symptoms is getting another infection. And I think if you're, in this very unfortunate position where you've had COVID and you've developed long COVID, and then you've had other, more COVID infections or any other infections, that sadly is a risk factor for causing a further deterioration in your long COVID. So, I mean, our advice to people with ME/CFS is to do what you can to avoid picking up other infections. And if you do get another infection, then as far as your pacing, your activity and activity management is, you just drop things down a bit. You really do get some rest and convalescence while that's going on, and don't try and push on with a new infection.
That's great, Charles. Can I say thank you so much for coming along and talking to everybody today, and thank you to everyone who's attended. The fact that there's been so many people on this call shows, that it actually does affect, a lot of people, and obviously it's a really interesting topic, and I think we could, as you say, talk about it all day. Apologies if people haven't managed to get questions into the chat, but as I say, if you do want to send anything on to me, sort of after the event, please do, and we can get those answered. The recording will be available on our YouTube channel, and we will send that on to the attendees, as well as a reminder about the resources that Charles has referred to in this presentation. So thank you everybody for giving up your time today. We hope to see you again at our next online session, and I hope you have a lovely weekend and enjoy the rest of your afternoon. Thanks, Charles. Thanks, everyone.
Thank you very much indeed. Thank you.